Good morning, everybody. Dr. Beckett, good to see your slides. Are you able to turn on your camera? Great. Good morning.
Good morning. Am I okay to get going?
No, why don't we wait until 8 and then Taylor here, our chief president, will give a brief introduction, brag about you a little bit. Oh. All right, Taylor, why don't we go ahead and get started? Taylor, should we do it?
Yeah, I'm ready if you all are.
Yep.
Good morning, everyone. Welcome to Grand Rounds. Today I have the pleasure of introducing Dr. Jordan Beckett. Dr. Beckett graduated from West Virginia Wesleyan College with a BS in biology prior to earning her Doctor of Osteopathic Medicine degree from WVSOM. She then completed a pediatric residency at Nationwide Children's Hospital and is currently a pediatric hospitalist and associate professor of pediatrics through WVU Medicine Children's at Camden Clark Medical Center in Parkersburg, West Virginia. She also serves as an adjunct faculty member at WVSOM, who instructs and mentors students during their pediatric clerkships. Please join me in welcoming Dr. Beckett.
Thank you, Taylor. So thank you guys so much for having me. So whatever member you are on the pediatric healthcare team, whether it's a general pediatrician or pediatric specialist or on the surgical team, or you're a hospitalist like myself, most days you're encountering a patient who is being fed breast milk and also a family member who is providing that milk. This talk is a combination of two talks I was fortunate to give at the AAP National Conventions in 2021 and 2022. And at that time, I was an outpatient pediatrician. And as such, I had a different role and interaction with breastfeeding families than I do now as a pediatric hospitalist, where I care for both newborns and hospitalized infants and children. So my goal is that whatever area of medicine you're in, you leave with some knowledge at the end of this talk on how you can support your breastfeeding patients and also your colleagues. I know personally, between my medical school and residency education, I received sort of the bare bones foundation on breastfeeding, and it was up to me to kind of fill in those gaps. I'm hopeful what I present today can help you supplement your existing knowledge on that topic. I'm also hopeful at the end of this talk that you leave feeling confident to advocate for breastfeeding women whenever you encounter misinformation, be it within your pediatric practice, your social circles, or within the hospital itself. So, like most pediatricians, I don't have any relevant financial information I need to tell you all. But for the sake of this talk, I think it is important that you all know that I did exclusively breastfeed both of my sons. My oldest, who is now 5, I nursed him for a total of 36 months, and I'm currently nursing my 12-month-old. I understand that my successful breastfeeding relationship was multifactorial, and I will go into that in a lot more detail in the coming slides, with a combination of my education, my strong family and work support, multiple lactation visits, my income, the color of my skin, where I live. I know that for many Americans and most of the West Virginians I serve, they do not have these privileges. So every 2 years, the CDC comes out with this breastfeeding report card, and it reviews how we're doing as a country in various areas of breastfeeding. So our most recent one looks at infants born in 2021. And as you can see, looking at the image over here, around 84% of infants breastfed at any point. So that could be 1 day, 1 month, or the entire 12 months. Around 84% of infants have breastfed. Looking at 6 months, the number goes down to around 60%, and then at 12 months, 39%. And again, this is all any breastfeeding, it's not exclusive breastfeeding. Moving to the right, we're looking at exclusive breastfeeding of infants born in 2021. Exclusive through the first 3 months, we have 46.5%, and then down to 27%. As you can see, over the last, over the last 8 years, we really are at a bit of a plateau. We had a tiny little blip between 2019 and 2020, but for the most part, we are at a plateau in our breastfeeding rates, both any breastfeeding and exclusive. But the point I really want to hit on for the sake of this talk is that 60% of families do not meet their individual goals for breastfeeding. So taking a closer look at that first 12 months of life, as you can see, as the months go on, our breastfeeding rates go down. And according to the CDC breastfeeding report card, how long a mother decides to provide human milk for her infant is dependent on a multitude of factors, including issues with lactation and latching itself, a mom's concern about is her baby getting enough, is her baby gaining enough weight, a mom's concern about are the medications she's taking safe while breastfeeding, unsupportive work policies, a lack of parental leave are huge, cultural norms and lack of family support, and then unsupportive hospital practices. So the areas in blue, bright blue, I did highlight because those are ones that we as pediatricians can and should make an impact on. And the one in light blue, although we may not be able to influence all of our patients' work policies, I think it's important that we within our WVU hospital system do whatever we can to support the breastfeeding culture within our institutions. So another look at our breastfeeding rates and within our state and compared to our neighbors. This map on the left looks at the percent of infants who are breastfed at 6 months. And as you can see, unfortunately, West Virginia is at the bottom 11 states. Zooming in, you can see West Virginia compared to Ohio and Pennsylvania, and that's compared to the United States average. And as you can see, unfortunately, West Virginia falls quite a bit below the mark in every category. As someone who did exclusively breastfeed through 6 months, it saddens me to know that I was only able to share in that experience with around 14% of other West Virginia women, and breastfeeding through 12 months in any capacity with only 19% of other West Virginia women. An interesting fact I want you guys to be aware of is that patients born in West Virginia or mothers who deliver in West Virginia who receive West Virginia Medicaid do receive an electric pump, but unfortunately it does not come till quite a few days after discharge. And unfortunately, it's a less than ideal type of electric pump. While our neighbors across the river in Ohio, which I deal a lot with due to our location at Camden Clark, those women receiving Ohio Medicaid get what's called a Spectra pump. And a Spectra electric pump is one of the top electric pumps. I used it myself in both of my children. So out of the get-go, our women who receive West Virginia Medicaid are already at a huge disadvantage. So a quick reminder of the benefits of breastfeeding. For those individuals providing breast milk, we do see decreased odds of diabetes, cardiovascular disease, including hypertension and heart attack, and ovarian and breast cancers. For those infants receiving the express breast milk, we do see it's protective against SIDS. We do see lower rates of ear, respiratory, and GI illnesses in the newborn period, and also lower rates of obesity and diabetes in older children. Emerging research is showing that COVID-19 vaccination does generate a robust immune response in the milk of those women, and it may provide their neonates protection from severe COVID infections. So we talked about how we're doing as a country and how we're doing as a state individually, but looking back, how far have we come? So looking back in the 1970s, we had our historically lowest breastfeeding rates. We were down to only about 21% of breastfeeding. In the 1970s, breastfeeding research really started to begin, and a huge thing that improved breastfeeding rates was the development of WIC. As you can see, the 70s moving into the 80s, breastfeeding rates increased. And then moving into the 80s, you can see that research that was started clearly documented breastfed infants had decreased respiratory illnesses, ear infections, and GI illnesses. So again, we had a bit of a decrease in the 80s moving into the 90s, but then in 1991, UNICEF and the World Health Organization launched the Baby Friendly Hospital Initiative. I won't talk much on that. I know that can be a hot button topic depending on who you ask, but excuse me. But as you can see, the Baby Friendly Hospital Initiative, or the Breast is Best movement, did have a steady increase in breastfeeding rates until we come to the mid 2000s, which is where we are at now. So we talked about how we're doing now. We talked about how far we've come as a country. So where do we go from here? So every 10 years, the CDC comes out with what's called the Healthy People Objectives, and there's specific ones for breastfeeding. So by 2030, the goals are that we increase the proportion of infants who are breastfed. So again, that's any amount of breast milk, not exclusive, whether that's 50-50 breastfeeding formula, 20-80, from where we're at now, around 36% to 54%. Then moving on to exclusive breastfeeding, the 2030 goals are to take our baseline of exclusive breastfeeding at 6 months from 25% to 42%. So those are pretty big goals. So how do we achieve those 2030 goals, knowing how we're doing as a country and how we're doing in West Virginia itself? So it's important for us as pediatricians to know that the decision to breastfeed is heavily influenced by other individuals, by family members, friends, their OBGYN, their pediatricians, their previous feeding experiences, social media with TikTok and the mom influencers. And it's important for us to know that that decision made to breastfeed is typically made long before they come to their newborn hospital visit. It's often even made long before they even come to the hospital to have the baby to begin with. In those early days, when you have an opportunity to interact with those women, I really encourage you, instead of saying, are you going to breastfeed or formula feed? Are you going to breastfeed or bottle feed? Really try and use some open-ended questions with those families, like, what are your thoughts about feeding your baby? Or tell me about your previous experiences feeding your baby. I think it's important that we acknowledge the barriers to breastfeeding for each patient, and we're going to go in those in deep detail, and that we tackle the ones we can and accept the ones we can't. But most importantly, again, whether you are a pediatric subspecialist, a pediatric surgical team member, or a general pediatrician, you need to dispel any myths and misinformation, have a low threshold to reach out to the specialist in our lactation department, and really support breastfeeding women as much as you can within your practice. So a quick look at a history of Fed is Best. I know you all have heard that phrase. You may have even said it yourself as a pediatric provider. So Fed is Best was developed in 2016 by ER physician and a nurse lactation consultant. So their mission is to promote safe breastfeeding and bottle feeding support. You will see across their marketing that formula saved all of my children's life, and it also saved me. Knowing that this is a fact for many of our patients, we cannot combat any anti-breastfeeding messaging we may hear within our patients, we may hear within our colleagues with anti-formula messaging. So we know that the Breast is Best movement that came in the 1990s did its job initially. We know formula is not the default option for women when they have babies. We know that the benefits of breastfeeding are widely known to our patient population, but we are at that plateau in our rates across the board and have for a while. So it's time for us to consider changing our messaging and changing our approach with our patients. So in 2011, the Surgeon General created a call to action to support breastfeeding women. And the Surgeon General identified 7 barriers to breastfeeding success. So in the coming slide, I've identified in 6 out of the 7 barriers a celebrity who has struggled with each of these barriers, and for whatever reason, it influenced their breastfeeding experiences. As we're going through these barriers, I really want you to kind of sit back and think about patient experiences you may have had, maybe your own breastfeeding experience or a family member or a colleague or friends, and think about how the presence of these barriers really changed their feeding experience. On my experience, I'm going to highlight my lack of these barriers and how that greatly contributed to my success. And within each barrier, I'm going to include some information you can potentially take home and back with your patients and colleagues to, like we talk about, dispel any myths and misinformation. Lost my mouse. Sorry. Lack of knowledge. So to me, this is the biggest barrier that I see within my patient population. So here we have Chrissy Teigen, who talks about she was working really hard pumping. She wasn't quite sure what settings to turn her pump on, how much volume. She was questioning, was her baby getting enough? This is something that I think was huge to my success in breastfeeding. In addition to being a pediatrician, I have taken upon myself to have extra breastfeeding education. And I know that I had a solid foundation, and I knew when to, number one, reach out for help from my lactation colleagues. I knew when misinformation was given to me by my dentist or an anesthesiologist or an urgent care provider who told me I had to pump and dump or delay breastfeeding. I knew to correct them. And I knew when to be concerned, and I knew when to feel reassured. I also wasn't swayed by an influential TikTok post by a mom influencer. So I knew a bit, and that was very helpful in my success. So, excuse me, as a newborn hospitalist, I really try and spend a lot of time with this, with any of our families who are providing breast milk for their children, and also when infants are readmitted for failure to thrive or hyperbilirubinemia, or at any point throughout their experience. I think it's really important that we continue to give this information. So number one, really normalize normal stomach volumes and urine output. I say the phrase, your baby needs as many wet diapers as they are day old that first week of life. I normalize weight loss. And explain that as long as it's around less than 10% weight loss and you get back to birth weight by 2 weeks of life, that's okay. In families who are approaching that increased weight loss, I talk about when to pump, how to pump, and go through all those different types of pumps, whether it's hand pump, an electric pump, a Haka, all those different things. You'll hear me normalizing feeding intervals. I think that is so huge as newborn hospitalists and outpatient pediatricians, or anyone who's interacting with newborns in those early days, that normalizing cluster feeding, and that isn't necessarily a sign of hunger. So many times our families see us following that 12, 3, 6, 9 feeding schedule, and then they're discharged home and see my baby wants to eat every 45 minutes. So going ahead and laying that groundwork before those questions occur. We talk about 8 or more in 24. I say that a lot. I have it on a badge that says, as long as your breast is getting stimulated 8 times, at least in a 24-hour period, that's the goal, those early days. I go ahead and touch on those safe practices in breastfeeding. When I see moms having their Starbucks on their bedside table, I say, oh, good for you, mama. You enjoy that coffee. Don't let anyone tell you you can't have coffee and provide breast milk, or you can't have your Taco Bell and provide breast milk. And then I touch on especially those early signs of engorgement of mastitis, a little tool that I use. I say your breast should feel like your chin, or softer. If it starts to feel like your nose, your breasts are getting engorged. If it feels like your forehead, it's getting too engorged. So this image, I really wish I had been given in early days in residency. I wish we could distribute it more to our patient population of what are normal volumes? Am I making enough with that? It's the question we see the most. So you'll hear me say this so many times because I want it to, stick in everyone's head that a normal volumes are 1 to 1.25 ounces per hour of milk away or per day. So between 24 and 30 ounces of milk a day is normal output. Anything more than 30 is an oversupply. So if you are working a 12-hour shift, you leave between 12 and 15 ounces for your child with your caregiver. I touch on this before they are discharged from the hospital. And before those questions, our slides not advancing.
They are. Linda, you might have something, some trouble with your own phone or whatever you're using.
I touched something. I didn't mean to say that.
Okay. All good.
Okay. So I touch on this before they're even discharged because so many questions come up in those first few days, or first few weeks about normal volumes. I talk about things like slow flow nipples, and how, unlike it's a lot of misinformation that nipple size should increase as babies go up. It's normal. Many breastfed babies will stay at the same size nipple their whole feeding journey. I talk about PACE bottle feeding. This little image on the bottom, I made my in-laws and my parents and my husband look at it, but I demonstrate that with families, especially whenever I ask, are you planning on going back to work? Are you planning on combination feeding? So really talking about understanding that feeding a breastfed baby can be different than feeding a formula-fed baby. And then after solids are introduced, shout it from the mountaintop, the volumes of breast milk do not increase. It is not like formula where volumes go up as they go old. So continue to feed those 4 to 4.5 ounces as the baby gets older. So another huge misinformation that I'm always trying to stomp out. So the second barrier, which I think tags along well with lack of knowledge, is social norms. Here we have Kim Kardashian, who talks about how she chose to formula feed because she felt like she could be more present with her other children and was more freeing. 45% of American adults indicated that they believe a breastfeeding mom has to give up too many habits of her lifestyle, and that commitment can be seen as threats to a mom's freedom and independence. Here's where I again talk about dispelling myths about diet and caffeine. I normalize sleep patterns, that it's okay your baby doesn't sleep 6 to 8 hours at night, and it's okay that your breastfed baby is skinny. My breastfed baby has never been above the 15th percentile, but he's chugging along his curve perfectly. But for so many of our patients, they see 95th percentile is what you have to equate health. I normalize combo feeding, so early on asking families, what are their goals? Are they really wanting to exclusive breastfeed or not? I normalize extended breastfeeding. So many women are uncomfortable talking about extended breastfeeding with their family, friends, or even their pediatrician. And then normalizing the all over the place happy spitters and stooling patterns we see with breastfed infants. They go from pooping a ton a day to around 1 month, they poop once a week. Poor family and social support. This is the third barrier and one that we struggle a lot with in West Virginia. You saw how low our breastfeeding rates, and they've been that way for decades. Here, Jennifer Lopez talks about how her mom didn't breastfeed, and that really influenced her feeding journey. With that, a 2017 study showed that a person's confidence in their success can have a marked impact on their actual success, and that right interventions can significantly increase that all-important sense of self-assurance. So those interventions I often see where family members are saying positive comments or negative comments or social media. So it's important for us to be mindful of what we are saying. My lack of barrier in this is I had an amazing family support. My husband stayed at home for the first 2 years of life. He washed all my pump parts when I would come home from work. My mother also breastfed. I live at a comfortable income, so I never had to worry about my utilities being turned off. I never had to worry about basic needs for our family. Knowing that this is a huge factor in the 2022 report card, you can see that infants receiving WIC are less likely to ever breastfed than infants who are ineligible for WIC. Most of our parents really struggle with this because they don't have a lot of family support with this, or they don't have a mother or sister who breastfed as well. So when they're in the thick of cluster feeding and having these questions, they often don't have that social support. So with those social questions, I really liked whenever, because they can be pretty heated, I try and use what's called the CVS method, if you're familiar with it. So clarify, which means tell me more, validate, your feelings are valid and common, and solutions. So I see this every time I'm on service. If you have any interaction with young children, you also see this. So it's day 1 of life or day 2 of life, the baby is fussy. In comes the mother and mother-in-law saying, hey, that baby looks fussy, she looks hungry, let's give her a bottle of formula. So for clarify, I say, okay, ma'am, tell me what she's doing to you that you think is hunger. And let's take a look at how many wet and dirty diapers she's had over the last 24 hours. Then I move on to validate. Okay, she is making some sounds that look like hunger cues, but babies have a lot of needs in the first few days and weeks, and it's really hard to figure out what they want. So validating parents' fears. I can't see that my baby's getting enough. How do I know, are they hungry? Are they fussy? And then solutions. So since your baby is making good wet and dirty diapers, we can see she's getting enough. So let's see if she wants to nurse, or maybe she just wants to, snuggle and cuddle. Newborns love to snuggle. So I use this method every day, but especially in some of those heated family situations, whether it's sleeping myths that you need to, add some formula to top things off to help baby sleep longer and more. And then the other social norm or myth that you can't have a social life, you can't travel. Here we see Blake Lively pumping at Disney World away from her child. And one thing that seems to blow everyone's mind is about drinking with breastfeeding. So when you are pregnant and you consume alcohol, your blood alcohol equals your baby's blood alcohol content. When you give birth and you breastfeed, your blood alcohol content equals your milk alcohol level. So let's say an example, let's say I'm turning one loose in the blue lot, celebrating a WVU victory, and my blood alcohol content is 0.16, which is 2 times the legal limit of normal in many states. That means my milk alcohol content is 0.16. And for reference, orange juice is 0.5. So you should never pump and dump when consuming alcohol. You should never, if you see someone doing it, stamp out that misinformation. So the next barrier, and one that is huge, is lactation problems. Here, Adele talks about how she struggled and she was told it should be natural, and it doesn't feel natural. It's hard. We need to know that 22% of women who want to breastfeed experience delayed, and what delayed means is more than 3 days milk production after birth, and that rate jumps upwards of 44% in first-time moms. So this is where my lack of barrier is. I knew when to call my lactation consultant friends. So my first son, I needed to have a nipple shield for the first 3 months. My second son, he had a horrible oral aversion, and I had to exclusively pump the first 4 months. So I'm not asking pediatricians to become lactation consultants, although I'm hopeful myself I'll be one in the spring. West Virginia has around 75 lactation consultants, but it is important that you can recognize red flags when you should provide your patients with that number. And it's important for us to normalize seeing a lactation consultant throughout that whole breastfeeding journey. It's not just those first few days and weeks and months of life. Some of these questions that our patients' parents may have is questions about what a latch should look or sound like. Again, is my supply okay? It's important that they ask us instead of social media, because they'll be told, take these cookies, do all these drinks, which are not evidence-based. Questions about, can I breastfeed if I'm currently pregnant, if I am having twins, if I have only one breast, if I want to potentially tandem nurse my newborn and my toddler. Questions about, is my baby getting enough? One thing that I always want to touch on is what's called a weighted feed. Sometimes a pump is, all the time, a pump is not always reflective of what the baby is getting, because the baby is more efficient than any pump. So what you do is you meet with your lactation consultant or an office that does this, is you weigh baby, then you breastfeed, then you weigh baby again, and that number can equate to how much a baby's transferring. So I myself, even as a pediatrician and someone with a solid breastfeeding education, I had to do this so many times throughout that first year of life, because my son went from nursing 20 minutes to nursing 10 minutes to nursing in 5. And because I couldn't physically see it, and I know he had a great growth curve, I still reached out to lactation consultants. And I really encourage you to have those numbers in your offices ready to hand out for any concerning patients. Another thing that was huge to my lack of barrier, in addition to having frequent lactation consultant friends who came to my house, is I'm a Caucasian cis female. We know that in in this, just in as many other areas of medicine, Black women experience systemic racism here, and fewer non-Hispanic Black infants are ever breastfed compared to Asian infants, non-Hispanic white infants, and Hispanic infants. So a quick little review of lactation basics is your mature milk starts appearing around day 2 to 5. Those later days are for women who are usually first-time moms and those who had a C-section. And those volumes gradually increase to about day 30 of life. We really try to encourage uninterrupted skin to skin that first hour. And that's another lack of barrier that I had. I had 2 routine spontaneous vaginal deliveries. I was never away from my child. I didn't have to have a C-section. My child didn't have to go to the NICU. So that beginning and having no birth trauma was a huge thing out of the get-go of my lack of barrier that so many of our patients don't have. It's important to breastfeed often, offer 30 minutes to 2 hours, and really work on watching those hunger cues. When again, oftentimes we see things done in the hospital at 12, 3, 6, 9, and understanding that that's not reality for many of our patients. Again, normal milk, 24 to 30 ounces, so 1 to 1.2 ounces an hour is normal. Questions about how to increase supply. The most important thing to know is you need to empty your breast completely. An empty breast makes milk faster than a full breast. So the next barrier, and one that I'm so thankful for working in these organizations, is employment and childcare. So here, Jessica Alba talks about how she had to cut her breastfeeding journey short because of work obligations. So according to a most recent breastfeeding report card, around 51% of employers have worksite lactation support programs, so not ideal. Federally, Americans are entitled to up to 12 weeks of unpaid parental leave. Not great, but that's what we have. And December 29th of 2022, the PUMP Act, so Providing Urgent Maternal Protections for Nursing Mothers, it's a great acronym, became law under the Fair Labor Standards Act, and it extended pumping privileges to millions of workers across our country, and really showing that employees are eligible to pump at work for a total of 1 year after their child's birth. I'm very thankful that, again, I live at a comfortable income, and my comfortable income allowed me to purchase wearable pumps. So I often pump while I'm rounding, I pump while I'm seeing patients, I pump while I am doing notes. Many of my colleagues who are surgeons are pumping while they're operating. So many of our patients don't have the financial means to afford one of these pumps. I'm very thankful that I have access to pump whenever I want. But again, many of our patients don't have employee lactation sites and don't feel that they can pump or store things appropriately while they're at work. So some things I hit on out of the get-go, and I love this photo. It's one of my favorite. We have Regina George pumping in her Spectra at a fashion shoot. So we talk about, how often should you pump? It's important to know that every woman has a different storage capacity. If you see a colleague only pumping 3 times, that doesn't mean you may be able to pump 3 times. You may need to pump 6 times in the same amount of time to maintain your supply. I go ahead and normalize, even in those first few days, Mama, you do not need a milk stash. Do you see those photos on social media of a deep freezer overflowing with milk? Can be disheartening to many of our patients who are making just enough or maybe only half. So if you're planning on providing milk for your infant, you need as much for your first day back at work. So again, if you work a 12-hour shift, you leave 15 ounces. And here's some, we go ahead and touch on how often you can leave a milk out, how often it can be in the refrigerator, and so on. So the last barrier, and one that I think we as a healthcare entity across our country do the worst at in supporting breastfeeding women. Again, my lack of barrier in this was huge. I knew when my dentist who was filling my cavity told me I should pump and dump, I knew that to correct him and hand him with some information I'm going to show you. And that same goes for medications and other radiologic procedures. So this slide right here, I wish we could make into a badge reel. I have it on my phone. I keep it in my pocket. I reference it weekly. I sort of become the person in our hospital that if a nurse hears a woman being told pump and dump on a floor, they find me and I go and meet with that provider and dispel that misinformation. So On the left, this is from the Anesthesiology Organization on the safety of anesthesia and breastfeeding. So more often than not, they are compatible. Kind of a rule of thumb with anesthesia is if you are awake enough and stable enough to feed your baby, feed your baby. Moving on to the right are radiologic procedures. And as we're going into October, I want to shout it from the mountaintops that there is no contraindication to obtaining a mammogram during lactation. You just need to nurse or express milk prior to getting your mammogram. As you can see, we should not be interrupting breastfeeding for x-rays, fluoroscopies, MRIs, or CT scan. So again, you may not be caring for that woman directly as a patient, but you are caring for a child who's receiving that milk. And if we want to change the culture and increase our breastfeeding rates across our country or within our state itself, we need to start changing the words we're using. We need to stop turning a blind eye whenever we hear the words pump and dump. So this also should be on the badge reel. So is this medication safe? So the first, we have infant risk, is a call center through the Texas Tech University. You can call if you want. There's also an app that I've purchased. It's not super expensive, but it is very user friendly. It has great information with the levels of evidence with that. There's two compatibility websites. The first is run by the NIH and the second is called Trash and Pump and Dump. They are both free and both evidence-based. So all of my medical students that I have had over the years, one of the main things they take away is that I will hunt them if I hear that they have told a woman to pump and dump, and they should not be. So the last barrier, and we have no celebrity, but here's me breastfeeding both my sons on Haunted Mansion at Disney World. So this is the one I think we're doing the best in as a country. So a recent CDC survey showed that 69% of responders believe that women should have the right to breastfeed in public spaces. It should be 100, but we're making moves. Especially in states like ours that have lower breastfeeding rates, we're seeing less women breastfeed, pump in public. This is still a pretty big factor. It's not limited to public settings. Some women feel embarrassment within their own family and friends. And it's often cited as a reason many women choose to either supplement or give up breastfeeding altogether. So again, we're doing better as a society, showing women pumping. You saw Regina George pumping, but we still are focusing a lot on the sexuality of female breasts. So doing better, but we still have a ways to go. So after reviewing these barriers, I'm sure you all can think of patient interactions you've had over the years, or colleagues, or even your own feeding experiences, and how some of these patients or people you know have experienced some of these barriers or even all of these barriers, and how those barriers can feel like mountains and how they can drastically change a dyad's feeding journey. So this editorial was in British Vogue in September of 2022. This is Ashley Graham, who's a model, and she works with formula company Bobby. And here she is showing combination feeding her twins. This editorial came at the same time as the American Academy of Pediatrics updated their guidelines in the use of human milk in breastfeeding, and many colleagues across the medical community and non-medical perceive them a little bit tone deaf, maybe a little outdated, given the pandemic, given the formula shortage and more. Ashley Graham in this editorial said, quote, "I'm ready to end the war on feeding. It's a war that the medical organizations like the AAP are unfortunately helping to fuel." So I'm a huge stickler when it comes to guidelines. Anyone who knows me, I love a good protocol, whether it's a UTI, ear infections, bronchiolitis. But when it comes to breastfeeding and knowing our patient population that I serve and knowing our breastfeeding rates over the last decade have not changed with the messages we've been given, I know that the feeding recommendations are not going to equal feeding realities. I love this wording. There is no one size fits all. I think that's perfect, and that aligns with my thoughts that the guidelines aren't for every single patient. And it's important for us to know as pediatricians that since breastfeeding success is complex and determined by a ton of different factors, and most importantly, until we as a country are able to support all moms, especially lactating moms of all socioeconomic statuses, across all communities and races with accessible lactation support, adequate paid maternity leave and childcare services, ample lactation facilities, and protected time at work. We have to meet these families in the middle with their feeding expectations because we're not supporting them as a country. So this phrase, this image was also from that editorial, and I love it. Your best is best. I say it often when I take care of newborns admitted for failure to thrive or hyperbilirubinemia, when moms are struggling to produce enough milk. Once I saw this in 2022, I said, I'm going to use that, and I use it frequently with that. So again, as pediatricians, how do we get to those goals? Or is it even attainable? 54% of any breastfeeding at 12 months, when the United States is at 35% and West Virginia is at 19.2%. So it's important for us to think, what are mom's goals and barriers? And starting to think about some breastfeeding versus exclusive. So the goals that I really want to focus on that I think are more realistic for my patients are this some breastfeeding. If a mom is really passionate about exclusive breastfeeding, then I obviously support that as well. But research has shown that even small amounts of breast milk per day can provide some immune protection, and that in infants born in 2019, the CDC showed that when supplementing with formula at 6 months, 56% of these women were still breastfeeding, while 25% were exclusive breastfeeding. So is formula the answer? I don't know. But this is each year about 80,000 newborns in the United States require readmission after discharge. The majority of these are hyperbilirubinemia or dehydration. And this is when I see so many women taking a pivot in their feeding journey. So this study, it was in Pediatrics in 2018. It looked at whether using 10 milliliters of formula in infants who were more than 75 percentile down for age and weight and whose mom's milk had not begun in yet. And so this early limited formula was given after each feed. And we looked at, does it interfere with readmission rates, intestinal microbiomes, and through 1 month as well. So in this population of healthy newborns who did have upper limits of weight loss, this early limited formula did not interfere with breastfeeding at 1 month, without formula at 1 month, or their intestinal microbiomes. It is important to know that in the study, 4 infants in the control arm were readmitted, while none in the early limited formula arm. So this may be an important therapeutic option. I do talk about this a lot in the early days, and how we can potentially prolong breastfeeding journeys in our patients. So in wrapping things up, how do we get to those goals? Is of 54% any breastfeeding when we're at 19%. So I know that with my best efforts and my best passions in education, I'm not going to get to those rates. So that's why it's important that myself and we as pediatricians really need to kind of shift our focus to best serve our patients and understand that those recommendations do not equal feeding realities because of the barriers that our patients are facing. We need to know that formula is a life-saving product for many of our patients, and it's a safe choice that many of our patients will choose in feeding their child in some capacity. We need to advocate for breastfeeding mothers and dispel misinformation within your patient population, within your social circle, and within our hospital system. So little by little, we normalize things, we dispel myths, we protect that milk at all capacity, and those numbers can kind of slow down over time, but it's a big culture shift. We need to acknowledge those barriers to breastfeeding and respect those barriers and know that they are mountains for many of our families, and thus individualize our feeding goals to fit the patient more so than the guidelines themselves. So we need to stop saying breast is best or even fed is best. I prefer and recommend using more neutral language like fed is first. So in those early days, we need to feed the baby. We know that breast is a great option in many cases, but feeding is first. We need to say things like every drop is a gift. So this is not breastfeeding. It is not all or nothing. For some reason, many patients have been told that you have to pick one or the other, but saying your best is best. If you can only breastfeed for comfort because you enjoy it and you want some of those benefits and you want to formula feed the rest of the day, that's great. If you want to do 50-50, that's great. So your best or your patient's best is best. And then finally, I fully support combination feeding, and it can often prolong your breastfeeding journey if you feel like that's best for you, given your barriers and given your limitations. So I want to end with this image on the left, and that I just love. Breast is not best, fed is not best. Best is being informed about normal newborn behavior and feeding. Best is knowing the red flags for feeding difficulties and when to reach out for help. Best is having a support system to help you make informed decisions and help encourage you in your feeding journey. Don't feed into the hype. And I love the policy statement from our brothers and sisters at ACOG and the ending that mother is uniquely qualified to decide whether exclusive breastfeeding, mixed feeding, or formula feeding is optimal for her infant. Thank you, guys.
Thank you, Dr. Beckett. Informative and material passionately delivered. Very important stuff. Let's open up the questions to see if people have comments. I'm a charter member of the Husbands for Breastfeeding because it's best for our kids, of course, but also, we should recognize that moms, women in this are performing the bulk of the work of feeding the baby, and so some of us dads take a little bit of a back seat, and one of the things that occurs to me is, yeah, my wife did the vast majority of the feeding at night because we were breastfeeding our infants.
I see.
Appreciative of that.
Dr. Pete was asking about that. Yes. Do we have the data about urine output in the first week of life for exclusive breastfeeding? Yes, I can get you that. I had my resources on the last slide, just quite a bit. But I should preface that that my comments are for healthy newborns. So that doesn't necessarily apply to the NICU population, but for most healthy newborn babies, a rule of thumb is 1. So the first 24 hours of life, you need 1 wet diaper, second wet, and go on with that. But yes, I can get that. So yes, Dr. Pete, I will get you that, absolutely. Dr. Costello, can you speak about donor milk, when to offer use, no payment, and access can be a challenge? So absolutely. So here in Parkersburg, we do not have access to donor milk. So I hit on this a little bit when I talked to the AAP, and understanding that even though AAP does not recommend using unregistered donor milk, understanding that many of our patients are seeking that out. Many of our patients are posting on Facebook asking for donations of milk. So I am unaware within my community in Parkersburg where we can buy it that is close by, that we can have our patients purchase donor milk. So that's why I really try and use that early limited formula and talk about introducing that early limited formula in like a syringe or in a slower flow population. I'm not sure what you guys have access to in Morgantown. I know in the NICU patients are receiving some donor milk, but it is important, we talk about recommendations and realities to know that many of our patients are soliciting donor milk on Facebook and receiving that. So to provide some recommendations about the safety or lack of safety when doing that. But I know it's expensive. I have some friends who have huge oversupplies that live elsewhere and make a decent amount of money doing that. But I can't really comment to that in my area because we don't have it. Most of our moms are getting it through other means. Dr. Saggio, can't underestimate the influence of family members. Yesterday, I had a grandmother tell her daughter that the baby didn't like her and liked the bottle better. Absolutely. So that's when I really try and use that CVS method of clarify, validate, because it's saying like, tell me why you think that, because we know in those early days, those feelings of confidence or lack of confidence can be instrumental. And especially in West Virginia, when we know many mothers didn't breastfeeding, we as healthcare providers may be the only people that are supporting them in those early days.
I feel like I have to say something as the self-appointed anti-baby friendly physician in the Department of Pediatrics. This is Courtney Mattini. Hi, Jordan. Good job. That was awesome.
Thank you.
I think your presentation is exactly the way it should be because, and I love the ACOG statement about how a mother is uniquely qualified to decide how to feed her baby. I just think that baby friendly is not that. They talk a lot about exclusivity all the time. They talk about keeping formula away from mothers, banning formula supplements. The measures that they look at are exclusive breastfeeding only, when the data does not support that exclusive breastfeeding is any better than co-feeding as far as using formula and breast milk. So I just want to say great job to you, but yeah, I just have to put my that still doesn't mean baby friendly is for us stamp at the end.
Yes, it's very, very frustrating, especially when you know what our patients are up against. And it's just unrealistic that they expect every patient to have the lack of barriers like I have. And maybe 2% of our patients will have that.
And Jordan, I will also then talk since Courtney did, but I think the presentation is awesome. And just also, there are moms out there who desperately want to breastfeed and it's not in their cards. And, I think having a supportive pediatrician who accepts, this is not defeat is super, super helpful for them and for their emotional well-being moving forward.
Yeah. And there's upwards of 44% for first-time moms. And then illustrating that these celebrities who could buy their own lactation consultant to live in their house are struggling, and our patients aren't. So that's why we say it's not natural. It's not easy. So yes, Dr. Rosser, definitely, it's frustrating. And that's why that ad by Ashley Graham, how sometimes the recommendations feel a little tone deaf at times when knowing where we're at as a country. The question, what are your recommendations for herbals such as fenugreek and increasing milk supply? Like I said, I hopefully will be a lactation consultant in the spring. Anecdotally, I tell moms that sometimes fenugreek from my research can have an opposite effect. And the most important thing, if someone's wanting to exclusive breastfeeding or increase their supply, is frequent feedings. Very much the more you demand, oftentimes the more your supply can be, to making sure you're fully emptying breasts. So I never really say supplements with that. The only time, so back when in the outpatient realm, we did work with some OBs and prescribing Regland in some select patients when looking at moms' previous health conditions. I did do that, but in my role as a hospitalist, I do not recommend supplements with that. As someone said, great job. Anyways, the hospital is trying to minimize barriers. So I'm really proud of our lactation clinic here at Camden Clark, in that it doesn't matter if you deliver here or not. You call our lactation number, they will see you as many times throughout your feeding journey. You just call, and our lactation clinic is also our newborn Billy clinic. So if you come back to our Billy clinic to get your Billy checked, you are being seen by an IBCLC nurse, who, even if you didn't come for any questions about feeding, they are there. They are very long appointments, so they can sit and have hands-on breastfeeding help. So I think having that, and we really try through social media campaigns, especially during breastfeeding month, but throughout the year, to give a shout out to our clinic and say, give us a call if you have any questions. We will help you. And I say that's the biggest barrier within our hospital of dispelling misinformation. I'm slowly, I met with the Department of Radiology. I met with the Department of Cardiology. Our head of anesthesia here is super breastfeeding friendly. He's a dad who, was great about supporting his breastfeeding mom. So those images that I showed with anesthesia with the bottle and radiology, you will see that throughout our hospital. And so I'm really proud that I feel like over the last year, even I've heard the phrase pump and dump, or I've had providers epic chat me and double check. So those are really the main things we're doing to minimize those barriers. Dr. Costello, Peds non-baby friendly fan, how well we should be amplifying more in West Virginia and beyond. Yes. we can't just focus on exclusive breastfeeding because we don't support exclusive moms for exclusive breastfeeding.
I've been wondering a little bit about the opioid epidemic and foster care or kids being raised by grandparents, how much that might impact the breastfeeding rates. And I think, clearly some, right? But it's probably mathematically a small amount. So it's
Yeah.
probably more our culture.
Yeah.
And we can't blame these other factors for the majority. We got
Yes.
work to do with our culture.
Our moms who do come in on Suboxone, we have some great partners within our hospital. Well, they really try and encourage breastfeeding in those patient population to help infants who are exposed in that way. But yes, I really do think it's a culture shift. And then when I see physicians, at the top level, dispelling misinformation, that's why the culture shift needs to stop at the top as well. If we expect, if we can't expect a dentist or an ER physician to tell a mom to pump and dump, and then that can trickle down and change her breastfeeding journey, we can't expect a mom who has little to no family support, little to no breastfeeding education to make those changes.
Right. Well, thank you very much for delivering, this excellent grand round. So kudos. And if you haven't already thought about it, but you should totally take this show on the road, maybe volunteer for the state AP meeting or other venues.
Yes. Oh, Dr. Lefevre has a great what are conditions for lactation support, number of consultants in hospitals and the nursery. I feel many of mothers have already stopped attempting to feed by the time they get to us because they receive little or no support in the hospital. So I can really only speak for an N of one. I'm really proud that we always have two usually lactation consultants in hospital. Nighttime sometimes is rougher times, but really trying to identify on admission which moms have some interest in breastfeeding. And I've told our intake nurses on labor and delivery, we've kind of used those words to, talk about, instead of saying, do you want to breast or formula feed, to really, in EPIC, it kind of asks you feeding choices for your infant to really try and be open with those. So I think that has been helpful to kind of lay that framework initially that, hey, you don't have to pick right now. And we're going to try all we can do to, minimize skin to skin. We as a hospital service, unless there's an issue, we don't go in and assess the infants until they're at least 2 hours old, to really try and protect that skin to skin time with those babies.
Good point. Dr.
Dr.
Sadhu?
I will get you that information. Thank you.
Renee, do you have a question?
Oh, no, I must have bumped it. Sorry.
Okay, no worries. All right. Thanks again, Jordan. Very nice. Well done.
Thank you, Dr. Mullet. Thank you, guys.